तो स्टूडेंट को कौन सा बोलना है ज्वाइन करने के लिए? हाँ ओके ओके, स्टूडेंट्स हैव जॉइंड, हाँ ठीक है ठीक, ओके ओके okay. So I don't know why the stream ended on its own. I have no idea, but some technical glitch and the stream ended on its own only. Okay, so that is okay. Let us start now. Yeah. Hello, hello, hello. Am I okay? Is it visible to all? Visible to all? हाँ भी हो जाएगा, स्क्रीन ब्लैक स्क्रीन हो जाएगा, स्क्रीन इज ब्लैक. Hello, hello, hello. Audio is good, video is black screen, but now it can be seen. Hello, hello, hello. Yes, now it should be fine. Just refresh once. Everything is okay from my end, students. Hello, hello, hello. Because I can see myself. Hello. Hello, hello, hello. I can see. What's how come the screen is not visible? Hello, hello, hello. Now can all of you see me? Can all of you see me? Can all of you hear me? Hello, hello, hello. This is yeah, frustrating too. Hello, hello, hello. अरे स्टूडेंट्स को सिर्फ वाइट स्क्रीन दिख रहा है, उनको मेरा वीडियो नहीं दिख रहा, ऑडियो दिख रहा है। यहाँ मेरे साइड से सब चालू है। हाँ बिल्कुल, OBS वर्चुअली है ना कैमरा। हाँ क्रोम मतलब वो जो बाजू के जो डॉट है ना, वो तीन अपना इसके लाइव के बाजू वाला ना। हाँ नीचे का सेटिंग, हाँ हाँ नीचे के जो सेटिंग है वो ना, हाँ एग्जिट एंड स्ट्रीम के पहले वाला सेटिंग, हाँ। आपको क्या दिख रहा है? तो क्यों दिख रहा है? देखो मेरा मेरा देखो, मैं आपको देखो, आप वीडियो कैमरा है तुम्हारा, ये देखो, ये देखो क्या है, ये देखे। क्या यार, टाइम वेस्ट हो रहा है ये। लॉकर इसको स्ट्रीमिंग बंद करके ना, एक बार लॉकर के फिर लॉगर, ये सब बंद कर दो फिर स्ट्रीम। हाँ हाँ सर, ये स्ट्रीमिंग बंद कर दो। Yes. Okay. So a lot of technical glitches, can't help it. Things are not in my control. It's really, I don't know why the first stream ended on its own, and now this was, I was able to see. But okay. Anyways, so now we were on this. Can all of you hear me? Can all of you see me? Yes. So we were discussing okay, when it's an immature axis and an ovulation, what is happening? What were we discussing? Anybody? Can you tell me? Please tell me, what were we discussing? That why an ovulation leads to menorrhagia is what we were discussing. Yes or no? So now please pay attention that what I was explaining you was this. Okay, sir, when the periods are regular, here the cycles are regular because regularly the ovulation is taking place, so lining grows and progesterone comes out, and this is like a normal flow or normal menses. Now when it is an ovulation, it is unopposed estrogen action, so lining keeps on growing, like 1 month no period, 2 month no period, 3 months no periods. But when there is no periods, the lining is getting accumulated inside, so there is, and the lining becomes so thick, and then when there is bleeding, there is going to be menorrhagia. It's like example what I was telling you was that if I shave every day, the shaving will be over in 2 minutes. If we have grown thick beard, thick beard we have grown like Virat Kohli, like Ranveer Singh, Hamza Ali, Mazari, thick beard, then when he starts to shave, it's going to take him 20, 30, 40 minutes. बात समझ में आ गया? Is this clear to all of you? कहने का मतलब ये है कि सिर्फ the lining only grows this much, lining grows this much, then the bleeding is this much, like example whatever. But the lining has only grown very tall, then whenever that lining will break, it is going to be menorrhagia. Yes or no? So what is typically going to happen, if somebody understand, is that there is going to be amenorrhea. There is going to be amenorrhea followed by menorrhagia. That is the typical presentation in an ovulation. Is this understood to all of you? Okay, sir, when the patient, can I get 10 thumbs up? Please put some photo with a thick beard. Okay, like example, अगर grass जो garden में grow होता है, okay, अंदर घास नहीं उग रहा है, just a way to understand. कि आप regularly lawn से grass को cut कर रहे हो, it will be getting over in few minutes. If grass has grown very tall and then you start to cut the grass, it's going to take a lot of time. Yes or no? So whenever there is amenorrhea, this amenorrhea is because of excessive estrogen. Yes, progesterone is absent, and therefore this leads to amenorrhea plus lining becoming thick. Okay, lining I'm writing, or the endometrium becomes thick, and that would eventually lead to menorrhagia. The lining will break, and that is going to be there. So there are episodes of amenorrhea followed by menorrhagia. Yes, exactly same thing will happen in this perimenopausal. यहाँ पे it is a young axis, यहाँ पे it is a dying axis. Patient is not dying. अगेन आपका सर्वेंट, जैसे मैंने बताया, सर्वेंट बराबर काम नहीं करता है. तो सर्वेंट अगर बराबर काम नहीं करेगा तो one day he will come for work, then 2-3 days he will not come, 1 month he will not come, then again he will come, then again he will not come. So same thing is going to happen. Is this understood? यहाँ पे it is a young axis, यहाँ पे it is a old dying axis. So one of the very important statements, all of you look on the board, which is going to help you remember things, कि at the extremes of menstrual career, the menstrual career from a female, for a female, is menarche to menopause. Okay, at the extremes, when the period starts, few months, few years also, there could be an ovulation. And when the periods are about to stop, finally periods stop, that is menopause, uske pehle bhi there is going to be an ovulation. Is this understood to all of you? So starting few years from 2013 years से लेके 16 17 18 years तक, example, just an example, if 12 years her period started, then 12 to 17, first 4-5 years, okay, between say 12 to 18 there could be there. And suppose example, this is just an example, okay, suppose menopause is happening at 50 years, and again somewhere 45 to 50 के बीच में again there is going to be an ovulation. बीच में फिर then cycles become regular. Is this understood to ovulate? Is then there in between there could be ovulatory cycles. Is this understood to all of you? It's just an diagrammatic representation to show you कि sir, when the patients are starting the periods and when the patients are finishing their menstrual thing, there could be an ovulation. Is this understood? Can I get 10 thumbs up? And I repeat, sir, अगर an ovulation होगा तो क्या होगा? Sir, an ovulation होगा तो estrogen unopposed हो जाएगा, lining बहुत thick हो जाएगा, and so it's like 1 month no periods, 2 months no periods, 3 months no periods, लेकिन 4th month जब आएगा एक साथ वो 4 months का साथ में आएगा, तो lining is becoming accumulated inside, and that's why estrogen unopposed is dangerous and bad for the patient. Is this understood to all of you? Yes. So this now in my, can you tell me what can happen in the middle column? So यहाँ पे an ovulation हो गया, यहाँ पे an ovulation हो गया, and इसको एक special name है. Anybody final years to gold medal? This an ovulation in this specifically 40 plus perimenopause, in this perimenopause patient is given the name MH. I will tell you what it is, but अभी किसी को पता है तो what is MH? MH क्या है? नहीं पता है तो I'll tell you, don't worry. Okay, MH क्या है? Okay, don't worry, MH क्या है? I will tell you in some time. Okay, I will tell you in some time. Very good study. Metropathia hemorrhagica. Don't worry, I'll tell you. Okay, picture अभी बाकी है मेरे दोस्त. Now चलो, tell me the causes in the second column. Excellent study. Okay, यहाँ पे second column में क्या क्या होगा? So when the patient becomes 20-30 years, so there could be problem of fibroids. All are other causes. Okay, chalo, tell me what are the other causes? Polyp, fibroid, polyps, endometriosis. Okay, adenomyosis. The glands of the endometrium grow in between the muscle fiber. Okay, and it's very similar to adenomyosis only. Endometrium. Okay, उसमें भी there's severe painful period, dysmenorrhea, menorrhagia. Okay, we'll discuss adenomyosis. Okay, ये सब all these problems start by the age of 30-35 and they go on till 40 plus, and all this problem will also continue in the second column. Is this understood to all of you? Third column. So it's a overlap. Because sir, fibroid, polyp, adenomyosis can happen from 35 to 45 years. So it's a overlap, same thing, same this thing you will write over here also. Same thing you will write. Okay? Fibroid polyp adenomyosis. Okay, clear to all of you? Now, thyroid disorders. Females are more prone to thyroid disorders, and all age group you should do thyroid because hypothyroid. So TSH is generally on the higher side. Okay, thyroid disorders can lead to menorrhagia. Now, very important, can I get some thumbs up? I hope you're understanding. And very important cause in my column number 1, exclusively column number 1, bleeding disorders. Okay, bleeding disorders like von Willebrand disease, and idiopathic thrombocytopenic purpura. What is this? Can you tell me why over here the bleeding would be heavy? Okay, when it's a platelet disorder or some von Willebrand hemophilia, the bleeding is not going to stop only. Along with that, they will give you history of easy bruisability, petechiae, bleeding from gums. ये सब history देंगे. A patient went for dental extraction, bleeding is not stopping. Okay, is it clear to all of you? I am not able to get you whether you are. I need some responses, students. I cannot understand whether you are understanding or not. Yes, coagulation. Very good, Basu. Coagulation defects. Okay, so coagulation defects hoga. So bleeding is more. Okay, so now all of you look on the board, and therefore, whenever I have a patient who is having puberty menorrhagia, young age group may do the platelet count. Platelets. Okay, BTCT. What is BTCT? Bleeding time, clotting time. With the clotting बराबर हो रहा है क्या नहीं? Prothrombin time, PT, APTT. Okay, all this they will teach you in your physiology and intrinsic pathway, extrinsic pathway, PT, INR, activated partial thromboplastin time. All these things should be done in a young patient. बात समझ में आ रहा है? I repeat, platelets, BTCT, PT, APTT. Okay, BTCT, bleeding time, clotting time, PT, APTT is your prothrombin time, activated partial thromboplastin time. Why? Because, sir, that heavy period is a manifestation of this disease. मतलब she is born with von Willebrand, तो गायनाक में क्या होगा? मेनोरेजिया. Yes, dental में होगा dental bleeding from gums. बाकी सब जगह होगा easy bruisability, petechiae, bleeding. Is it clear to all of you? So all this coagulation defects can cause menorrhagia. But all of you look on the board. If from year to year, suppose यहाँ से लेके यहाँ तक periods are normal, then here suddenly she can't develop von Willebrand because they inherited, it's congenital. So suddenly it cannot appear at 40 years of age. Is it clear to all of you? Okay, so if I tell you a question, just a virgin MCQ, just for me to know that whether you have understood or not, is, okay, suppose a lady comes to you and says, Doctor, I am 45 years old. My menarche periods suppose started, whatever period started at the age of 13 years. Okay, 13 years my period started, 13 to 23, 23 to 33, 33 to 43. Last 30 years periods were normal. ऐसा स्टोरी आपको देंगे. 45-year-old lady comes to the OPD having menarche at 38, and now last 30 years the periods were normal. Now since last 2 years there is heavy menstrual bleeding. There is heavy menstrual bleeding and heavy flow. What is not the cause for this heavy menstrual bleeding? Tell me. They'll give you fibroid, polyp, hyperplasia, cancer, adenomyosis, and von Willebrand ITP. So what is not the cause for this? यस, वेरी गुड सर, कि कुछ भी होगा वॉन विलीब्रांड नहीं हो सकता है, बिकॉज इफ इट इज वॉन विलीब्रांड डिजीज, राइट, सिंस मेनार्की पीरियड्स, क्लैप क्लैप क्लैप, ठोको ताली, टुडे मॉर्निंग व्हेन यू गॉट अप ओजी इन द चैट बॉक्स, आज सब सुबह उठे थे, ये बात पता नहीं था, अभी दोपहर तक पता चल गया. व्हाट एम आई सेइंग इज दैट सर एनीथिंग एल्स, यस सर, इट कुड बी फाइब्रॉइड, it could be polyp, it could be adenomyosis, it could be cancer, whatever it is, it could be anything else, but it cannot be von Willebrand. समझ में आ गया आप लोगों को? Yes. Okay, why? Because अगर von Willebrand होगा तो सर बचपन से, right since menarche, the period would be heavy. Is this clear to all of you? And last thing, anybody want one more point to be kept in mind in 40-45 plus patients? Okay, lower down in the list, lower on the list, but you need to keep it exclusively in the first column. Anybody? First column में और क्या आपको याद रखना है? Last column, sorry, in the last column, 45 plus patients, perimenopause, what other important thing I need to always rule out first? Yes, very good, Basu. Endometrial hyperplasia, endometrial cancer. बात समझ में आ रहा है? Because why? Sir, majority cancer happens in postmenopausal lady, 50, 60, 70, but even in perimenopause 45 plus, if the periods are heavy, you need to rule out hyperplasia cancer first because of the age. Very good. And again वो young age में नहीं होगा. Is this understood to all of you? Okay, so all of you look on the board. Very very important 5-star 7-star slide. 5-star slide you need to do understand. Okay sir, whenever there is a menorrhagia in different age group, HPO axis immaturity leads to an ovulation, and an ovulation में यहाँ पे होगा, and HPO axis immaturity में there could be amenorrhea followed by menorrhagia. मतलब 1-2 महीना, 1-2 months period stops and then it's very heavy flow, then again 1-2 month period stop, again it is very heavy flow. Okay, coagulation, DUB is the same thing. Okay, the same thing. This is called as dysfunctional uterine bleeding when there is no obvious spell. This word is outdated now. The DUB word is not used. DUB word is now outdated. We don't use the word DUB, but just to explain to you the meaning, the same thing. This anovulation को ही हम DUB बोलते हैं when there is amenorrhea followed by menorrhagia. Okay, is it clear to all of you? But this word DUB is no longer used. Okay, so you don't have to remember it. Okay, endocrine disorders, I told you thyroid disorders you need to keep in mind, and coagulation defects like ITP and von Willebrand disease. समझ में आ गया? In my reproductive age group, fibroids, polyps, adenomyosis, thyroid disorders important. And in perimenopausal, again an ovulation or infrequent ovulation, thyroid disorders very important, fibroid polyp, and always rule out hyperplasia cancer first. So please understand this age is important. आप puberty girl में hyperplasia cancer mark करोगे, wrong. आप perimenopausal में ये coagulation defects mark करोगे, wrong. Is it clear to all of you? So all these things, this table becomes very important. You should perfectly know the what do you call the age group wise causes. Now very important, one more point, keep in mind, whenever I have a reproductive age group patient, okay, whenever we have a patient in the reproductive age group, say example 20 to 40 years के बीच में, okay, very good, Basu. Why? Always there'll be one option. Okay, sir, I would want to do UPT or serum beta HCG. And why rule out pregnancy? Why rule out pregnancy? Why? Sir, pregnancy में तो period stop हो जाता है. Correct. Pregnancy the period stops. Then why are you teaching us this rule out pregnancy in menorrhagia topic? Menorrhagia में तो heavy bleeding है. Anybody? Why I need to rule out pregnancy? It is not the cause for menorrhagia, but why? Please understand this. Why I need to rule out pregnancy for what? Yes, that's sir, pregnancy complication. Why I need to rule out pregnancy? Because sir, there are certain pregnancy complications. Like what? Sir, it could be a abortion, miscarriage, incomplete abortion, or your threatened abortion. Abortion. We'll discuss all this in our obstetrics class next week, or even ectopic pregnancy. So patient could be pregnant and the management is completely different. बात समझ में आ रहा है? So there could be pregnancy complication which can mimic menorrhagia. Okay, like patient getting bleeding, heavy bleeding. So you think it is gynec patient, actually it is obstetric patient. It's a pregnant patient. Pregnancy complication, maybe there could be heavy bleeding. Pregnancy complication में there could be heavy bleeding, which you think it is menorrhagia. बात समझ में आ गया? Is it clear? I'm not saying pregnancy will cause menorrhagia. Is this 100%? Can I get 10 thumbs up? I need 10 thumbs up. So in reproductive age group, you need to rule out pregnancy for all patients, because that can confuse the doctor, and doctor can think it is menorrhagia. Okay, but actually it is a pregnancy complication, and therefore pregnancy complications like your incomplete pregnancy complication. So it is not a cause. But pregnancy complication you need to rule out. Okay, it is not, I repeat, it is not a cause of menorrhagia. It will look like menorrhagia. It will present with heavy bleeding. Okay, so ये table आपको याद रखना है, 1 mark आपका sure है. Okay, now coming with this as the basic thing, we come to the management. Management again depends on the same 3 column. Okay, one, you have got the puberty age group, 12 to 18 years, puberty and peripuberty. Second is 20 to 40 reproductive, and third is 40 plus perimenopause, 45, 43, whatever. Now, can you tell me, understand this? In the first column, we will always, because they are young girls, they are virgin pop, what will you do? Medical treatment or surgical treatment? Anybody? First column, medical treatment करेंगे या surgical treatment? Yes, can you tell me? Yes, always medical management you will try. By that medical management, what do we mean? So we can give them tranexamic acid, ethamsilate. Okay, tranexamic acid you can give, ethamsilate you can give, and very popularly we give OC pills or only progesterone, because progesterone is absent, right? I told you, an ovulation and progesterone is absent. So either you can give her OC pills or progesterone to control the bleeding. You can keep on giving them progesterone for 5-10 days, then the withdrawal bleeding happens. OC pills can also be given cyclically, few cycles. And as a last option, please don't mark it in the exam, only if it is absolutely life-saving, then we can do a DNC. DNC matlab dilatation and curettage, because when we remove, it's like sir ke pura, see, understand this, ke patient is bleeding. When under one shot I remove all this lining. When you remove all the lining, the bleeding will stop. Of course, lining will regrow next month, but temporarily the bleeding will stop. समझा? So DNC is almost never done. It's never done, only on paper. It's only on paper as a last resort. Okay, last option. Okay, ठीक है, समझ में आ गया? Mark नहीं करना है, just to complete the topic. In my second column, we can give 2 to 3 cycles of OC pills or progesterone to control the bleeding. And if still the patient is not responding, you will go and do a DNC. Of course, you will do sonography, all that is understood. Thyroid disorders, sonography, blood test, ultrasound, all that you will do is understood. And can you tell me, what will I do in my 40 plus patient? क्या है बेस्ट? ना रहेगा बास, ना बजेगी बांसुरी. क्या है 40 प्लस? चलो, वर नॉट दिस. ओके, 45-year-old patient, para 3 living 3, heavy menstrual bleeding since last 6 months. Since 6 months, what is the next best step? OC pills, LNG intrauterine device, hysterectomy, and a DNC. Chalo, tell me, what is the best thing to be done? What next? Very good, very good. Anybody? Why never? Why never? I'm so happy. Can you tell me why majority students across India, जो ओजी गुरु के स्टूडेंट्स नहीं है, ओजी इन द मेजॉरिटी स्टूडेंट्स को, अपने फ्रेंड्स को पूछो कि 45-year-old है, para 3 living 3 है, menorrhagia 6 months, 99% student will mark hysterectomy. It is wrong. Why? 99% students will mark hysterectomy and they will say it is wrong. Why? Why it is wrong? Okay, the thing is, never, I'm not saying don't do hysterectomy, never directly, okay, never directly go and do a hysterectomy. Why? Because sir, if I remove the uterus, and then the histopath report comes out to be cancer, I have done an inadequate operation. बात समझ में आ रहा है? I have done an inadequate operation. So, because for cancer, I will have to remove uterus, cervix, fallopian tube, ovary, lymph node, omentum, सब कुछ निकालना पड़ेगा. Otherwise, menorrhagia, only uterus, cervix I will remove. Is it clear? So like simple hysterectomy, radical hysterectomy, which hysterectomy I will do? That will depend on what the problem is. Why D is the answer? Anybody? I agree with all of you. Why D is the answer? Why D? D correct, but why? Okay, because sir, whenever I have got a perimenopausal patient who's having his heavy menstrual bleeding, I need to rule out. Yes, you need to rule out endometrial hyperplasia and endometrial cancer first. Is this understood to all of you? Yes, very good, Koshika. I'm coming to that. But the logic is, please draw 5 star, please draw 7 star around this line. Okay, इसके बाजू में 7 stars, 1 2 3 4 5 6 7. Okay, sir, you need to rule out endometrial hyperplasia, endometrial cancer first, because sir, if it is cancer, then the hysterectomy which I will do will be different. If it is not cancer, only hyperplasia, then the hysterectomy which I'll do is different. So after DNC, yes, you can proceed to hysterectomy. And all of you forgot why you want to remove the uterus. Isn't it? Can you save the uterus? Yes. जैसे क्या है, इंडियन गवर्नमेंट क्या बोल रहा है? सेव द टाइगर, सेव द लायन, सेव द चीता. डॉक्टर बोल रहा है सेव द डॉक्टर, इंटर्न बोल रहा है सेव द डॉक्टर, एफएमजी स्टूडेंट बोल रहा है सेव द एफएमजी. यस, सो सेव द डॉक्टर, सेव द स्टूडेंट, सेव द tiger lion, and save the uterus. Sir, we can also try LNG IUD. I told you Mirena. Patient anyway 40-45 plus है, Mirena डाल देंगे तो क्या हो जाएगा? Anybody? What will happen? How will Mirena work? कल ही बताया. LNG IUD. What is LNG IUD? LNG IUD, when you give continuous progesterone induced amenorrhea. It will control the bleeding. Patient is 45 plus, she will reach 50. Menopause aa gaya, remove the Mirena, uterus is saved. Okay, because LNG IUD, I told you, causes progesterone. Yes, progesterone induced amenorrhea, and you can save the uterus. But again, if it is cancer, I cannot put this LNG. Then I will have to do hysterectomy. Okay, so after DNC, so first you need to do a DNC. DNC why? To rule out. You need to rule out endometrial hyperplasia, endometrial cancer. And then based on this report, sir, either we can go for progesterone tablet, injection, LNG IUD, or of course then do hysterectomy also. बात समझ में आ गया? Can I get 10 thumbs up? तालियां बजती रहनी चाहिए. Okay, OG in the chat box. So first, your hashtag crystal clear concept should be there. Okay, DNC. And if the DNC is not in the option, endometrial biopsy bhi chalega. Anything. And the best, sir, put in a telescope. जो सिखाया, sir, put in a telescope, hysteroscope, and then take the biopsy. So whatever you do, you can even do hysteroscopy plus biopsy. All are doing the same thing. What all are doing? Sir, whether this, all of you look on the board, sir, whether I do a DNC, one, or I do a endometrial biopsy, or I do a hysteroscopy and biopsy, all of them is doing one histopathological examination, HPE. Write down these words, HPE. In a perimenopausal patient, HPE is mandatory. Okay, why I need to do DNC? Because sir, histopathological, because आप पेशेंट को देख के नहीं बोल सकते हो, oh, you have got hyperplasia, you do simple hysterectomy, you have got cancer, you do radical hysterectomy. Okay, you go for radical. Okay, HPE is mandatory. Mandatory का मतलब समझ में आ गया? Compulsory. Histopath, because hyperplasia cancer can only be ruled out under microscope. Okay. So progesterone. Okay, so all of you look on the board. One of the most important slides of our entire lecture series. Sure shot 2 marks आपका pocket में 7 star. All of you please read. I want all of you, wherever you are listening to me, at your home or hostel or multiplex or theater, please read this. Okay, sir, whenever we have a perimenopausal age group, histopathological diagnosis should always be made first to rule out hyperplasia cancer before proceeding with any treatment. Okay, hysteroscopy and biopsy are preferred to a DNC, because DNC is a blind procedure, but DNC is also okay. Hysteroscopy is preferred. Okay, and management is then dependent on the histology report. If there is no evidence of malignancy, then you can try Mirena, DMPA, or endometrial ablation, or even a hysterectomy. If the patient is not ready for follow-up, then you can do this. And of course, if it's cancer, you have to treat at risk per cancer. Is this understood? So HP, why? Because you need to rule out hyperplasia cancer first, which can only be ruled out on histopathology. Is this understood to all of you? Yes. ओके सो आई वेरी क्विकली रिपीट, दिस अ वेरी इंपॉर्टेंट टॉपिक. आपको ये टॉपिक में ये पूरा दो ही टेबल याद रखना है. दिस वन टेबल विच आर द कॉजेस, यू नीड टू फिट इट प्रॉपरली and you need to remember about the management in the age group wise. So the logic is that in the first column DNC always last, in the last column always DNC first. Okay, DNC or your either DNC first or that's the same thing, basically biopsy. How you biopsy or DNC, because dilatation curata, that is for histopath. Okay, so basically HPE, histopathological examination, is mandatory, and then depending on the report you will then decide the management. Will you want to save the uterus? Yes, put Mirena. You want to do hysterectomy? You can do hysterectomy. Is it clear? I'm not saying don't do hysterectomy. Never directly do hysterectomy. ठीक है, इतना सब समझ में आ गया. द लेटेस्ट थिंग, ओके सो ये आपका हो गया. एंड देन द फर्दर डीएनसी. नाउ द नेक्स्ट पार्ट जो मैं ये बोल रहा था कि there is one special word called as MP, MH, metropathia hemorrhagica. Okay, metropathia hemorrhagica. Only 3 words you have to remember, 3 important words. It is a term where there is heavy bleeding. It is specifically in this perimenopausal age group. In perimenopause, when the patient is perimenopause and because of this anovulation, क्या होगा? एक आप वेरी कॉमन, आपके मम्मी आंटी ग्रैंड मदर को भी कभी कभी ये हुआ होगा. सर 1 महीना नो पीरियड, 2 महीना नो पीरियड, 3rd महीना नो पीरियड, फिर 4th मंथ एकदम हैवी ब्लीडिंग. सेम लॉजिक, बिकॉज ऑफ एनोव्यूलेशन. एनोव्यूलेशन में ईस्ट्रोजन प्लस प्लस प्रोजेस्टेरॉन एब्सेंट. Okay, so metropathia hemorrhagica mein, because of anovulation, there are episodes of amenorrhea followed by menorrhagia. Okay, but this is in the perimenopause age group only, this word. Okay, so all of you look on the board. It is called as metropathia hemorrhagica या Schroeder's disease. Virgin MCQ, tough MCQ, glandular hyperplasia. All of you look on the board. This is seen in perimenopausal lady. I've already explained to you. The word is important. Perimenopausal because of an ovulation. Everything is explanation is over here. The classical feature is amenorrhea followed by menorrhagia. Explanation I've already given. I'm repeating. As there is no ovulation, there is unopposed estrogen action. So endometrium leading to thickening of the endo. I told you. Okay, same thing what I've already told to you. This thickening of the endometrium. This 1 month no period, then no period, then no period, then under. So lining becoming thick. Okay, and then the lining breaks. Okay. So as there is no ovulation, there is unopposed estrogenic action, and the endometrium keeps on becoming thick, leading to amenorrhea. And after the amenorrhea, the endometrial shedding will happen, leading to heavy periods. Okay, and when you look at the histopathology, very important, you will see Swiss cheese pattern. Please by heart, because there are empty glands. Why empty glands? Small and large empty glands. Why empty glands? Because there is no progesterone. There is no secretory changes. Okay, empty glands and absence of secretory changes. Why absence of secretory changes? Because there is no progesterone. There is no progesterone. समझा के नहीं? Okay, so therefore, since there is no progesterone, why no progesterone? Because of anovulation. So anovulation, so no progesterone. So there is absence of secretory changes. And similarly, now can you tell me the last thing? एक बार ये MCQ आता. What is corkscrew glands? Corkscrew shaped glands. Okay, anybody? ये normal है? This is normal or abnormal? What is this corkscrew shaped glands? Corkscrew shaped glands, very good. They are, sir, normal. Every female is normal in the progesterogenic phase, normal in the progesterone or secretory phase. Okay, is this clear to all of you? So sir, if here common sense, okay, sir, if there is absence of secretory changes, even that is going to be absence of corkscrew glands. Okay, very difficult virgin MCQ for FMG exam 3 years back in JIPMER. In JIPMER, this question had come. Okay, absence of corkscrew glands, yeah, corkscrew shaped glands seen in fibroids, prolapse, CA cervix, metropathia hemorrhagica. चलो, tell me the answer. Very simple. Of course, अभी सबको पता है metropathia. तो 3-4 नाम देंगे. Absence of corkscrew glands is seen in metropathia hemorrhagica. Why? Because sir, there is an ovulation. And ovulation होगा तो progesterone is going to be absent, and when progesterone is absent, there is this absence of corkscrew glands. Is this understood to all of you? Okay, and absence of corkscrew shaped glands. Okay, is this understood to all of you? Yes. So please keep all these points in mind. These are short MCQs which are going to come in the exam, and you cannot make a mistake in this. Okay, the last thing is a new classification for this all abnormal uterine bleeding, and that is the Palm-Cohen classification. Latest, just this word Palm-Cohen, it's a FIGO classification, Federation International for Abnormal Uterine Bleeding. Now what is the question? आपको खाली इतना आएगा. Palm-Cohen classification is a new classification for fibroid prolapse, AUB. You mark it as abnormal uterine bleeding. Now what is this Palm-Cohen? Anybody? ये Palm-Cohen क्या है? It's a mnemonic. Okay. Palm-Cohen is nothing. Palm-Cohen is nothing great. It is nothing great. It was always there in front of your eyes. Palm-Cohen क्या है? Sir, each word. P stands for polyp. A stands for adenomyosis. L stands for leiomyoma. M stands for malignancy, hyperplasia. C stands for coagulation defects, what I told you, von Willebrand ITP. O stands for ovulatory dysfunction, matlab ke the anovulation, what we discussed. E is any other endometrial cause. I is iatrogenic, if you have induced IUCD or whatever, iatrogenic. And N is not yet classified. Okay, is this clear to all of you? So Palm-Cohen is a latest word, and all of you look on the board. It is nothing great. Why nothing great? Because sir, just a way of putting all things together. All of you look on the board. Last Palm-Cohen, I showed you the slide for the first time. Barabar? Yes or no? This Palm-Cohen slide I'm showing you now for the first time. But last 45 minutes say this Palm-Cohen was already in front of your eyes. How? Sir, this what I had shown you, this is nothing but Palm-Cohen. ये वाला देखो, ये जो है, yes, sir, this one 5P, ये आपका Palm-Cohen का है P. All of you look on the board. ये P polyp, ये adenomyosis, ये L leiomyoma fibroid, ये M malignancy and hyperplasia. Is it clear? ये C coagulation defects, ये O ovulatory का and ovulation. समझ में आ गया? So Palm-Cohen is like nothing great. ये जो सब था, ये सब Palm-Cohen. This is nothing but Palm-Cohen. Clap if you have learned something new. आपको खाली इतना याद रखना है कि Palm-Cohen classification is for what? The Palm-Cohen classification is for abnormal uterine bleeding या menorrhagia. Okay. And of course, you should know every word of Palm-Cohen, what it is. Okay. P stands, I repeat, polyp, adenomyosis, leiomyoma, malignancy, hyperplasia, coagulation defects, ovulatory anovulation. Okay. Yes. So Palm-Cohen is a classification for abnormal uterine bleeding, which could be for these any of the causes. Okay. Yes. The last thing all of you, which is very important, what is, ये हो गया आपका menorrhagia is heavy periods. What is polymenorrhea? What is polymenorrhea? Just to complete the topic. And what is oligomenorrhea? And if polymenorrhea के साथ there is heavy period, then you call it as polymenorrhagia. Okay? Polymenorrhea is different and polymenorrhagia. ये दोनों में क्या फर्क है? Okay? And oligomenorrhea, क्या है meaning? What is the meaning of all these words? Can you tell me what the meaning of all these things? Okay? And heavy periods का opposite scanty period. Okay? Yes, very good. So cycle length. Okay, when the patient is getting more. Now, what is the normal cycle length? Okay, again tell me. What is the normal cycle length? Anybody? Normal cycle length क्या है? What is the normal cycle length? So please understand this. K 21 plus or minus 7 was considered to be normal. I repeat, was. 21 plus or minus 7 matlab, sorry, 28 plus or minus 7. Okay, 28 plus or minus 7, sorry. Okay, that means anything from 21 to 35 was considered normal. It means if a patient says, doctor, I'm getting periods every 22 days, every 30 days, it is all considered normal. Okay, normal cycle 28 to 30 days, but still 28 plus or minus 7 was considered normal. Was, I'm writing was. Okay, that means when the cycle is short, patient says, doctor, I get periods every 20 days, I get periods every 18 days, that is short cycle. So polymenorrhea का मतलब है के frequent menses, जल्दी जल्दी आ रहा है. Frequent menses, indirectly it means short cycle. Okay, short cycle, but the flow is normal. When there is this short cycle, plus heavy flow, cycle short plus heavy flow, then you call it as polymenorrhagia. Is this understood? Clap. Two words mixed together. Yes. Okay, and when there is long cycles, like जो अपना typically PCOS में होता है, long cycles every 40-45 days, patient says, doctor, I get periods every 45 days, 50 days. Okay, 45-50 days, that is long cycle, that is oligomenorrhea. But now the recent advances, excellent all of you, please understand this. Very recently the WHO and the FIGO, they said कि सर यहाँ पे let us add, I don't know why they did, कुछ फर्क नहीं पड़ता था, but 3 days more has been added, and therefore now we consider anything between 24 to 38 as a normal cycle length. Clap if you have latest recent information. Very good, all of you. Gaurav, Koshika, Shipra, Kirtana, Gaur. Okay. Okay. This is the recent advances. Now the new normal cycle length is considered between, that means if a patient says, doctor, I get periods every 24 days, very good. I get periods every 30 days, 35 days, 30 days also, okay. So this is the normal cycle length, is normal length. So therefore anything less than 24 days is called a frequent cycle. Okay, patient says, doctor, I get every periods every 20 days, 18 days, that is polymenorrhea. And if it's heavy also, polymenorrhagia. If I get periods every 39-40 days, that is oligo. So they can give you 4 words, they can tell you patient, identify what it is. Okay, so they say patient has periods every 23 days, it is normal? No. Patient has period every 25 days, it is normal? Yes. Okay, so please keep this in mind. Okay, is it clear? So all these are latest advances which sure you get the questions on, and keep this point in mind, and palm को inlet test. Okay, nothing more can be asked. I repeat, the most important आपको take home message यही वाला है कि please rule out hyperplasia cancer first, and this I repeat is the single most important slide. पूरे topic का this slide is the most important. Perimenopausal age group. Okay, now we are not going to take a we'll take a break in some time. We are continuing the same link only. Okay, because now it's working, everything is working smoothly. I don't want to disturb it again and start a new link. Okay, so let us begin the next topic, and that is prolapse uterus. Prolapse. Now, anybody, what is prolapse? It's a displacement of the pelvic organ. The uterus come down from its normal anatomical position. Now, can you tell me what are the supports of the uterus? And what is, so prolapse is a displacement. Prolapse mein hardly ever questions are coming. Mainly the management question comes, which I'll teach you, but I'll teach you the whole topic. Mainly the question are going to come on your management of prolapse. Okay, but what are the supports of the uterus, and what is anteversion, and what is anteflexion? Chalo, tell me this before we proceed further. Anteversion क्या है, anteflexion क्या है? What is anteversion? What is the angle? What is anteflexion? What is the angle? Total confusion. So lifelong you will not forget. Remember, V for virgin, V for vagina. Matlab wherever there is vagina, we use the word. Very good. Okay, so the strong supports, the cardinal, we're coming to this in a minute. Very good, very good. Very good. Okay, so all of you look on the board. The uterosacral ligament and the cardinal ligament. What is another name for cardinal ligament? Very important. Broad ligament and round ligament, they do not have much strength, and they're the false supports of the uterus. False supports of the uterus. Okay, so what is any other name for cardinal ligament? Yes, very good. The cardinal ligament is MACKENRODT. One name is McEnroth's ligament. Please remember this. And another name is, both mean the same thing, transverse cervical ligaments. Okay, transverse cervical ligament, transverse cervical. Okay, transverse cervical ligament. मतलब क्या होता है? All of you look on the board. All of you look on the board. If this is the pelvis, if this is the pelvis, and this it's a cut section. Okay, it's a cut section. Suppose this is the cervix. This is the patient ka cervix. Okay, So there are ligaments which are going from the cervix. पीछे है sacrum. Okay, पीछे है sacrum. So these are the uterosacral ligaments. Uterosacral ligament. Okay, this is the sacrum. I'm writing S. Okay, sacrum. And the ligaments which are coming from the lateral pelvic wall and laterally, this is which ligament? Anybody? So this is, sir, the cardinal ligament. Okay, cardinal ligament or the transverse cervical ligament. Okay, is understood to all of you? Attaching the cervix to the lateral pelvic wall. Okay. Then the levator ani muscle or the pelvic floor and perineal muscles from the perineal body are considered true supports, and broad ligament, round ligament, they do not have strength, so they are considered false supports. Now coming to this question of anteversion and anteflexion kya hai? Please understand this. The axis cervix is like this and vagina is like this. So angle between the cervix and the vagina, okay, this is the patient's cervix, okay, and this is the direction of the vagina, okay, and the bend of the uterus, uterus itself is bent upon itself, uterus ऐसा bend होता है. So the angle between the long axis of the cervix and the long axis of the uterus, I repeat, V for virgin, V for vagina, wherever there is vagina, this is vagina. So this 90-degree angle, anteversion, this is the cervix. समझ में आ गया? So angle between the cervix and the vagina, okay, like you can keep it like obviously this. Okay, so when you do the PV from here, okay, अब जब PV करते हो तो cervix you directly hit it. Okay, so this is your anteversion, but the cervix bend, this is the long axis of the uterus. Okay, long axis of the uterus and the cervix, this bend is your anteflexion. That different books are different. 120 degree you can remember, 120 to 135, that's okay. ठीक है. So anteversion, anteflexion समझ में आ गया? Can I get 10 thumbs up? Anteversion is 90 degree angle between cervix and vagina. Angle between cervix and vagina is 90 degree. Okay. And bend of the uterus on itself is the anteflexion, angle between flexion and the this. Okay. Now, can you tell me why should the prolapse uterus happen? Because simple one line prolapse क्यों होगा? Sir, supports will become weak. Supports become weak. Okay. So can you tell me why the supports will become weak? Supports will become weak क्यों? So sir, supports will become weak because sir, two things. One is menopause, old हो गया, बुढ़ा हो गया. Okay, so majority patients of prolapse you will see in the perimenopause, postmenopausal lady. Okay, majority patients are 45, 50, 60, 70-year old patients, postmenopausal lady. Okay, and second very important, childbirth. Every time when the baby passes through the birth canal, it is stretching the pelvic floor. So again delivery, again repeated vaginal delivery. Okay, yes, multiple pregnancies. Okay, repeated pregnancy, prolonged labor, obstructed labor, everything to do with labor and delivery. Okay, precipitate labor, improperly conducted delivery. Okay, so traumatic childbirth, repeated pregnancies से ज़्यादा भी repeated deliveries. Okay, vaginal delivery. Okay, postmenopausal atrophy, chronic cough, constipation. Okay, chronic cough, constipation can worsen the condition. Okay, so mainly childbirth and menopause. and connective tissue or the tissues can become weak. The tissues can become weak, like the tissues can become weak, like the connective tissue disorders. So here the tissues are becoming weak, here they are already weak, like Ehlers-Danlos syndrome, Marfan syndrome, all that. Okay? Now, please understand this. What are the degrees of prolapse? Anybody? What are the degrees of prolapse? 1, 2, 3, 4. ये क्या है degree? Anybody? First degree, second degree, third degree, fourth degree. Okay? Yes, anybody? What are the degrees? So ध्यान से सुनेंगे. Please understand this. First degree to fourth degree. This is of the uterine prolapse. Uterus coming down. Okay. Now the introitus. This I am drawing is the vaginal opening. Vaginal opening. Okay, and this is supposed the uterus. This is supposed the uterus. This is the cervix. This is the patient's vagina, and this is the vaginal opening. Vaginal opening or the introitus. Okay. Very good, Koshika. So ध्यान से सुनेंगे. All of you look on the board. All of you look on the board. Yes. So let me just draw with different colors so that all of you understand. Okay. The cervix, I am drawing it in green color. Cervix is in green color so that you just understand. And the vaginal opening, say suppose, is in blue color. Okay, blue color. Okay, now all of you look on the board. Whenever the cervix, I'll not draw the uterus. Okay, ये uterus है. Whenever the cervix comes down, normally cervix is at the level of ischial spine. Okay, whenever the cervix comes down into the vagina, it could come down over here, it could come down over here, all that is first degree prolapse. When the cervix is at the level of opening, that means you make the patient lie down directly, you are seeing the cervix, that is second degree. Obviously fundus आपको है, every time I don't have to draw the fundus. Okay, when the cervix is outside the intra, that is third degree. Cervix outside, but the fundus is still inside. Okay, so you can see the fundus is still inside only. And when the whole of the uterus including the fundus is outside the introitus, that is fourth degree, also called as procedentia, complete prolapse. Okay, very simple. I repeat, cervix is into the vagina up to the level of introitus, very good, outside introitus, and whole uterus outside the introitus. Whole uterus outside introitus means the fundus also. See, यहाँ सब में ना fundus is inside. In third degree the fundus is still inside. You can see the blue, the black part is above the blue. Barabar. See the black line, this black color I am drawing. The black color fundus is still inside. But when it is like this, it is like this. Okay. So all of you remember, very important, first degree cervix is into the vagina, up to the introitus, outside the introitus, whole fundus is outside the introitus. Please keep these points in mind. These are very important for the exam. It may or may not come. Okay. Now, तो आपका ये टाइप्स ऑफ सपोर्ट्स ऑफ द यूट्रस, डिग्रीज ऑफ प्रोलैप्स, ऑल दिस इज सिंपल एग्जाम्स, सिंपल थिंग. नाउ वेरी इंपॉर्टेंट, ध्यान से सुनेंगे. 10 minutes we gonna break. All this what I told you is mainly the uterus coming down. No, now it's okay. Okay, so all this what I told you was the uterus coming down. Just refresh it once, it will become better. Just refresh it once, it's better now. Okay, so this is the yes. Okay, so all of you look on the board. This what I showed you is the uterus coming down, degrees of prolapse. This is of the uterus. Okay, uterus coming down, uterus prolapse. Okay, but very commonly in exam, so this is your uterine prolapse uterus, which as I told you can be first to fourth degree. Very commonly in exam we get vagino-uterine prolapse. Now can you tell me what is vagino-uterine prolapse? Vagino-uterine prolapse क्या है कि सर vagina will also prolapse because all the supports are becoming weak. So इसमें क्या होता है कि सर vagina prolapses first और फिर वो यूट्रस को बोलता है चल तू भी मेरे साथ बाहर चल, चलो लेट्स गो फॉर अ वॉक, चलो घूमने चलते हैं. Okay, so can you tell me what will I see or what will I get if the vagina also prolapses? The vagina also prolapses. Yes, vagino-uterine prolapse. But what will happen when the vagina? What will you see? Okay, so very important. Please pay attention. For this little bit knowledge of anatomy is required, and you will see. Just tell me what are the vaginal components of. If I ask you what are the vaginal components of prolapse, तो क्या होगा? So all of you look on the board. All of you look on the board. Okay, sir. This is the anterior vaginal wall. Okay. This is the anterior vaginal wall. This is the posterior vaginal wall. Okay, very good. Okay, yes. Now, here is the cervix and here is the uterus. Very good. उसका बात नहीं हो रहा है. I am not discussing this right now. Yes, sir, the uterus is coming down. That is fine. That is fine. The uterus coming down, that is okay. I am not discussing that right now. What are we discussing is, okay, what? So this is the uterus coming down. Okay. This is the uterus coming down. That is different. Okay. Now, suppose this and आगे क्या है sir? In front of the vagina, we have got the bladder and the urethra, and posteriorly sir I have got the rectum and the colon, right? Anybody? The normal anatomy. Now if the anterior vaginal wall is firm, then the bladder is also over here. But now if this blue is normal, okay, ध्यान से सुनना, blue is normal. Now sir, suppose this vagina became lax and loose and became this green color, okay, ये loose पड़ गया, vagina became loose, anterior wall and even this posterior wall. Okay, vagina became lax and loose. So the bladder will also come down now. Yes or no? Thumbs up. Nobody will explain to you like this. Okay, sir, now this bladder which was here This bladder will come down here like this, and the rectum will come out like this. So this bulge which you see is called as cystocele and rectocele. Okay, it's like the bladder coming down. Bladder, you don't see the bladder, you will see a bladder bulge. पर्दा है, लेकिन पर्दे के पीछे क्या है? ब्लैडर है. पर्दे के पीछे क्या? ओके, इसका मतलब क्या है कि सर, you will see a bulge, and behind, from the bulge, through the vaginal wall, the bladder is trying to come out. So of course vagina is there. There's a vagina. This is the anterior vaginal wall. This is the anterior wall of the vagina, and उसके पीछे there is a bladder. Okay, so this bulge which you see is this. Okay, so depending on which wall of the vagina prolapses, okay, depending on which wall of the vagina prolapses, so in the upper anterior vaginal wall, cystocele is there in the upper part, and lower part urethrocele. And posterior के लिए remember the mnemonic CRP. Clap if you feel happy. CRP का मतलब है colon, rectum, perineum. कैसे याद रखना है? फ्रॉम अबव, all females have this sequence CRP, सबके लिए normal, colon, rectum, perineum. All females have this from above down, nothing great. So when the upper 1/3, सबसे पहले colon, that is your enterocele. Okay, enterocele. Okay, middle 1/3 rectocele, lower 1/3 lax perineum. Okay, is this understood to all of you? So upper 1/3, it is upper 1/3, middle 1/3, and lower 1/3. Okay, is this understood to all of you? And you get all these names as enterocele, rectocele, lax perineum. Okay, and out of all these varieties, cystocele is the most common. Very important MCQ. Commonest type of vaginal prolapse, cystocele. Okay, is it clear to all of you? So they can now tell me the answer. Okay, tell me the answer. Okay, so depending on which wall, depending on what happens and what prolapses, like the bladder prolapses, you call it cystocele. Even above the rectum is the colon. So when the loops of colon, when the colon herniates, you call it as enterocele. Rectum herniates, this. Okay, rectocele. And prolapse, and lower 1/3 lax perineum. Okay, so you can get various. So now tell me the answers, all of you. Okay, first I'll give you the options. Okay, cystocele, okay, ये suppose आपके options है. Now tell me, if I tell you anterior vaginal wall, upper 2/3 prolapse, what is it called as? Anterior vaginal upper 2/3 prolapse is called as cystocele. Very good. Okay, posterior wall, upper third, posterior wall में सबसे ऊपर, upper third prolapse. Yes, it is enterocele. And suppose posterior wall, middle 1/3. Posterior wall, middle 1/3, rectocele. समझ में आ गया? Clap. Okay, so depend. So these are all the simple papers. Questions आपके लिए mainly prolapse का types, variety. Then we'll, okay. Okay, so you have got degrees of. Now, can you tell me what are the symptoms? I'm coming to this in a minute. Yes, elongation I'm teaching you. What are the symptoms of prolapse? How will a patient present to you? It's very common. What are the symptoms? Okay, so very simple, very standard. SCOPV. SCOPV का मतलब है Doctor Sahab, something is coming out. Okay, something coming out per vagina. Okay, there is dragging pain, so low backache. Then bladder bulge ho jata hai na, bladder bulges down. So what happens is that there is a pouch formation. You see, bladder has gone down. Barabar? This bladder has gone down. Bladder has gone down. Okay, so the bladder will not completely empty. Okay, she will pass some urine, thoda urine will always remain inside. So more frequencies, you have to again and again go urine, again and again go for urine, because it is emptying. Emptying is difficult. Okay, emptying is difficult. Okay, more in incomplete evacuation. So generally it is a postmenopausal lady. Generally, young patients can also discuss, we'll discuss that. Yes, a postmenopausal lady or a multiparous patient complains of SCOPV, something those who are new, something coming out per vagina. Okay, low backache, dragging pain. Okay, about symptom, and it's exactly like hernia. When the patient lies down, symptom disappear. When the patient is standing, straining, coughing, prolapse is more. Sensation of bulge, heaviness. Okay, what is this decubitus ulcer? I will tell you in 5 minutes. Very important MCQ, decubitus ulcer. Okay, and urgency, frequency, because of incomplete evacuation. And sometimes patients say, doctor, I have to push the bladder. I push the bladder, then only I can evacuate. Okay, so manual reduction of prolapse part needed to start or complete the voiding. All that आपको नहीं पूछेंगे. The symptoms are just to finish the topic. What is decubitus ulcer? I'm telling you in some time. Okay. Okay, so types, degrees, varieties of prolapse आपका हो गया. Surgeries were discussed in the next part in this, and this one, and your causes of prolapse. Okay, तो इस पे सब पे question आ सकता है. And cystocele is the most common variety of vaginal prolapse. Please keep that in mind. The last thing before we go on a break, this elongation I will show you, and surgeries I will tell you in a minute. उसके पहले the last part, what is decubitus ulcer? And what is the treatment? Last year ka question, 2 years back. What is decubitus ulcer? Which prolapse? You see it in which degree? First, second, third, fourth. Which degree prolapse you will see a decubitus ulcer? Very good. Only when the cervix is exposed outside. Okay, only when the cervix is exposed. So on the exposed part of the cervix. Okay, so generally you see it in third and fourth degree. What is decubitus ulcer? So it's a circumferential ulcer, pura round, 360 degree ulcer is break in the continuity. Okay, so full round and round, round and round aisa, there's going to be a ulcer. Okay, there's going to be a ulcer on the exposed part of the cervix, पूरा आगे पीछे. Okay, there's going to be a ulcer. red आपको दिखता है. Okay, and it will be seen in a prolapse. Okay, so it is seen in it's a completely circumferential ulcer. Why does it happen? So because older theory was because of friction between the thighs and trauma, but the latest theory is congestion. It's because of congestion. Okay, because when there's a prolapse, there's a lot of congestion of the muscles because of congestion. Vascular theory. Okay, so congestion, जैसे आपको अल्सर्स होता है सर्जरी में सिखाते हैं वैसा. Okay, so circumferential ulcer on the exposed part of the cervix. Okay, so it is very good seen in third degree and fourth degree prolapse में दिखेगा, and it is a because of venous congestion, and it's a circumferential ulcer, that's called decubitus ulcer. And very important, what is the management for this? Chalo. Yes, very good. Okay, excellent all of you. So remember, you're not supposed to cut the ulcer, cautery कुछ नहीं करना है. You're supposed to pack. Packing. Okay, option में आपको क्या दिया था? Cut, laser, surgery, suture. No, you're supposed to pack it. Packing with what? मतलब just like dressing. How you do a dressing. So what you do is you take a. This is the vagina of the patient. Okay, and ये prolapse है. So you take a tampon. Okay, a gauze piece. Tampon is like a gauze piece. मतलब tampon is like where you collect them for menstrual blood. So there's a tampon, and that tampon we dip in glycerine and acryflavin. Excellent, all of you. Now we should know the reason for each one of them. Why do we use glycerine? So, sir, glycerine is a hygroscopic agent. It will decrease the edema. So, glycerine decreases the edema, and acryflavin. Okay, acryflavin is a yellow color liquid. It has got it's a dye. It has got antiseptic and antibacterial property, and it is helping in healing of the ulcer. So we take a tampon. पहले ये ग्लिसरीन एक्रीफ्लेविन का लिक्विड लेते हैं और एक टैम्पोन लेते हैं, और वो टैम्पोन में टैम्पोन को सोक कर देते हैं. ओके, ये पूरा टैम्पोन डाल देते हैं. वेरी गुड. Okay, so you will take a tampon. The tampon is dipped. Tampon is dipped in glycerin acryflavin liquid and just push it inside. So दिन भर that tampon will be there. It'll release it, and of course it takes time. It can take 10, 15, 20 days for the ulcer to heal. Every day you have to do daily. Okay, daily packing. Okay, packing or dressing with a tampon soaked in glycerin plus acryflavin. Okay, so it will help in healing of the ulcer. This is what you need to know in decubitus ulcer. Very, very important. Okay, so whatever we have discussed till now is 50% of your prolapse, the supports of the uterus, the symptoms of the patient. This picture I'm going to show you, and types of prolapse, degrees of prolapse, and your decubitus ulcer. When we are taking a short break of 10 minutes, 10-12 minutes, and when we come back, we are going to discuss all the different surgeries for prolapse, young patient, old patient, including the sling surgery. Everything we'll discuss, and the new thing, what is this grid classification, grid staging, all that we are going to discuss, and then continue the last topic, which is the fibroids also. Okay, is it clear to all of you? So here we take a small break for 10 minutes and we come back in some time. Okay. So this stream I'm ending and we'll start in the new stream.